Welcome to Biomedicine's 40th webinar and the first formal webinar in our Naughty Nephrons kind of renal series that we've been doing. We did have one done by our fabulous co-founder Rich on AKI last week, so do check that out as well. But we have a whole host of renal type webinars coming up this week. Oopsie daisy. So for those of you who don't know me, my name is Azim. I'm one of the co-founders of Biomedicine. We've been running these webinars throughout COVID, and we hope to continue these indefinitely for as long as we possibly can, and as long as you guys still want to watch these. So hopefully we can continue them for a much longer. So let's dive in with some aims, objectives, and some housekeeping announcements. So I guess the big question is, why have we moved on to renal? Well, I think most people would agree that renal is a pretty confusing topic. It's not necessarily taught particularly well at medical school. So as I'm sure you guys probably know by now, we like to keep things super simple and taking you through that whole patient journey from pathophysiology all the way to prognosis. But yeah, I think simplicity is the key when it comes to renal topics. You can easily overcomplicate it. So we're going to try and do our best to keep things really, really straightforward for you guys, whilst covering everything you need to know for exams. Today's topic is on renal stones, which is technically a urological topic, but kind of comes under that umbrella as well. And just a few general announcements before we move on to the aims and objectives of today. So certificates, I know a lot of you guys are emailing about certificates. Most of these should be sent out. Our friends at Medigate are currently processing the certificate from the last 5 or 6 webinars. So please just hold tight. If you still haven't received them in the next few days, you can pop them an email at info@medigate.com. But yeah, they're the ones processing our certificates, and we're super, super grateful for their support. Please also check out our website, biomedicine.com. Join us on Facebook, Biomedicine for Students, where you can join our community of, like, I don't know, 6,000 people now, which is pretty crazy considering how it all started. So yeah, please, Biomedicine for Students as well. And check out our schedule for the rest of the week. So moving on to the aims and objectives of today. As I said, we're going to try and cover essentially everything you really need to know for renal for your exams, and hopefully when you get to become foundation doctors or PAs as well. So all the way from pathophysiology to prognosis. We're going to offer you a few important differential diagnoses as well in that journey. And for those of you who don't know, we are super, super supportive of the case-based approach to learning. That's how Schwabe and I and Rich all kind of got through our medical school exams using that approach. So our whole platform on biomedicine.com has over 1,200 multi-step SBAs. So the way that we're going to work through this case today is this multi-step SBA approach. So if you like this, please check out our question bank at www.biomedicine.com. I'll answer as many questions as I can, probably at the end, but of course, as usual, Schwabe is in the chat to help you guys out, and we probably should be done in around an hour, give or take. So let's dive right in. So I think I was in a pretty weird mood when I first made these slides, but which of these is a stone? Okay, what is this first of all? Hopefully you know that's not a stone. This is a pufferfish. Yes, it's not a stone. But this is a stone, and I thought it looked like a pufferfish. Do not tell your consultants that this patient has a pufferfish stone, because they do not exist. But they look pretty similar. This is actually a spiculated kidney stone. There's a 1 centimeter calcium oxalate stone, which was retrieved from a patient's renal pelvis. Hopefully some of those words will make some more sense as we go along. But the reason I'm putting a few of these slides in is because a lot of people talk about renal stones like they're really small microscopic things, but that's pretty big. That's one centimeter. These types of stones have also been described as morning star stones. I say also, I mean, they haven't been described as pufferfish stones, but I have seen it being described as morning star stones. So a morning star is this weird medieval weapon. So it kind of looks like that, but I prefer pufferfish. What are these? I think I then got pretty hungry when I was making these. These are garlic dough balls. I prefer them from Pizza Express, but you can get them from various places. These are not dough balls. These are 4mm kidney stones. What are these? These are chicken nuggets, straight from Burger King, also known as nuggies to some. These are not chicken nuggets. These are calcium oxalate stones. So I thought they reminded me of that. I'm not entirely sure why I put these in, but you know, pretty entertaining. So these are, this is actually really interesting. So if we have a look at this slide on the right with the actual renal stones, you can see the measurement here, 1mm, 2mm. So these are fragments of a larger 1 centimeter stone. So if we take this stone on the far left, you know, this is 0.5 millimeters. And imagine the whole stone was 1 centimeter. So massive. So, you know, this was the fragment after being blasted with lithotripsy. So, you know, these are pretty big. So moving on from that interesting introduction, let's have a look at our main case that we're going to be covering today. So case-based discussion number 1. So we have a 35-year-old male who's presented to the emergency department with a 2-hour history of severe, sudden onset, right-sided flank pain radiating to his groin. So if you guys know anything about renal stones already, I think most people know, you know, we describe this as loin to groin pain. He's vomited once, there he is vomiting away, and he has no lower urinary tract symptoms. So things like dysuria, hematuria, those types of things. He has none of those. He has had 1 previous renal stone. On examination, there's right flank tenderness, but no other findings. Have a look at his observations. What do we think about those? Are we worried about those at all? Tacky, yeah? I mean, I wouldn't be massively worried. He is tacky, he's a little bit hypertensive, his respirate's a little bit up. But, you know, his temperature's fine and his sats are fine. So, you know, I'd make a note of these, but I wouldn't be massively concerned. Probably the tachycardia and the hypertension are the main things we need to try and resolve. So based on this, remember those. We're going to move on to our first question. We're going to be using Mentimeter today. Hopefully this works. So remember that case history and remember those observations, and go on to menti.com and type in the code 586772. 586772. So please try not to answer in the chat. Please answer on Menti and we can work through these options. So remember, chap presented, we think he has a renal stone, right-sided flank pain radiating to his groin, vomiting, tachycardic, hypertensive. You are the doctor or PA in the emergency department. What are you going to do? So I'll give a few moments for some more people to reply. Try and get a few more people. Yeah, you guys. Oh, a slightly larger split than I initially expected. Interesting. Okie dokie. Well, the correct answer is PR diclofenac. The main split here is going to be urine bit by the looks of things, but let's have a chat about these options. So essentially, we have a patient who we think has a renal stone. They're presented with unilateral loin to groin pain. They are vomiting, and they've had a previous stone, and they're a pretty young male, all of which are very suggestive of a renal stone. As per the British Association of Urology Society guidelines, after your initial assessment, if you are strongly suspecting a renal stone, you should administer an NSAID, so non-steroidal anti-inflammatory drug, so something like diclofenac or ibuprofen. This can be given
via any route. So it can be given orally, it can be given rectally in the case of diclofenac. In the UK, in A&E, all the renal stone patients I've been given, by the time I've seen them, even before I've seen them very often, they've already actually received some PR diclofenac. PR because, you know, faster onset, has better bioavailability. The route is there, it doesn't really matter. Obviously, a urine dip is going to be important because we need to look for microscopic hematuria. But as per the guidelines, after your initial assessment, if you're strongly suspecting renal colic, i.e. a renal stone, then you want to give an NSAID as soon as possible. Things like dihydrocodone and morphine, these are both opioids. These actually have a poorer analgesic effect and more side effects than NSAID. And the whole, you know, the tachycardia is all secondary to pain, most likely. So giving them a bolus of IV fluid is not going to do really much here. So hopefully that makes sense for everyone. You know, essentially, pain relief, you want to give an NSAID, it's the best, is the golden rule. So why do we think this is renal colic, and why are we so strongly thinking down that route? Well, severe, unilateral, sudden onset, loin to groin pain is the classic description of the pain in renal colic. He's vomited, often occurs due to the pain as well. Previous renal stone, big risk factor. And then also his age and gender. We're going to talk about the risk factors specifically, but both of those are risk factors for renal colic as well. And then we've discussed his observations. These are likely secondary to pain. So hopefully all of that makes sense to you guys. Obviously, we're going to talk a little bit more about the symptoms. We describe this as renal colic because, you know, in exams and in textbook, it's described as that pain that comes and goes, and with those kind of intervals of pain-free period. But, you know, in reality, often this pain can be longer lasting with very few intervals of pain-free periods. So, you know, it's things like biliary colic, where the pain actually comes and goes. In renal colic, it's often not as distinctive as that. This pain can last longer without pain-free periods as well. So that's just something to be aware of. So a little bit of an introduction. So nephrolithosis, which is also called the presence of stones, essentially, or calculi. That's the presence of calculi within the renal tract. That's what nephrolithosis is. In terms of some general risk factors, we're going to talk about some specific ones in a moment. Typically occurs in 30 to 60-year-olds, twice as common in males, associated with dehydration and previous kidney stones. So the chap, you know, in that case, he was between 30 and 60 years old, he was male, and he had a previous kidney stone. So big factors to point you in the direction of a renal stone. Good. Before we dive into all the clinical stuff that I'm sure you guys really want to know about, I think we really do need to start off with some basic anatomy, because if we don't know this, then the rest is ultimately pointless. So I'm sure everyone knows, you know, your kidneys are these two bean-shaped organs, really posterior abdominal structures, retroperitoneal. You have the kidneys here, you have the ureters coming down here. They come down towards your bladder, and on the route towards your bladder, they cross over your iliac vessels, usually at the point at which the common iliacs bifurcate into the. They then enter obliquely into the bladder, as you can see here. And if we go back up to the top, obviously you've got your renal arteries coming off your abdominal aorta and your renal veins coming off your IVC. Really straightforward. This is why I love urology, is like, you know, fair enough, the medical side of renal is complicated, but the basic anatomy in urology, to me, it makes a lot of sense. Now, the one thing that a lot of students often don't kind of discriminate between in their mind is the difference between a renal stone and a ureteric stone. Now, obviously, these are two very different things. One is in the kidney and one is in the ureter. So when we talk about renal stones, particularly if you're talking to a urologist or you're referring to a urologist, you can't just say kidney stone. You can't just say renal stone unless you actually mean renal stone. So you can see renal stone up here and a ureteric stone down here. Another kind of key point to remember is that these stones,
often don't just stick in one place. These stones can move. So you can have a renal stone, which then comes down your ureter, goes into your bladder, and then passes out your urethra, and you essentially pass out the stone. Happens very commonly. And some of these stones can be asymptomatic as well. So those are a couple of things to be aware of, that the stones can migrate, and particularly small stones, that often is the case as well. So if we focus on the renal stone, three main types that I want you guys to be aware of, mainly for when you're discussing with your urology registrar or trying to refer a patient, you actually need to be able to visualize these types of stones. So as we said, the kidney is retroperitoneal, it's very posterior within the abdomen, which kind of explains why you get that flank and back pain. That makes sense. So we have, I'd recommend kind of reading a little bit more in detail about the anatomy of the kidney. It's pretty interesting. But we have the renal pelvis here. The renal pelvis then goes down and forms the ureter. So understandably, it makes total sense. A pelvic stone is one sitting in the renal pelvis. A PUJ stone, PUJ stands for pelvi-ureteric junction. Pelvi-ureteric junction, we break that down. Pelvi means related to the pelvis, ureter related to the ureter. So it's at the junction of the renal pelvis and the ureter. That's a PUJ stone. And then a calyceal stone, you have the major and minor calyces. So a calyceal stone is essentially one that's sitting in one of the calyces. So really, really easy to understand. Visualize this picture and then you will understand where these stones are actually sitting anatomically when you're describing them. Nice. I see a few people mentioning the water under the bridge thing. I will touch on that in a few slides. So that's a little bit of the anatomy we were talking about. So moving away from renal stones, let's have a think about ureteric stones, and let's specifically zoom in closer onto the bladder. That's what this red circle is depicting. Let's zoom in on there. This is my very crude image of a bladder and a stone. So this is your bladder. These are your ureters piercing the bladder obliquely, bilaterally. And this is a VUJ stone, vesico-ureteric junction stone. We break down that word. Vesico means related to the bladder, ureteric related to the ureter. So these stones can also become lodged and obstruct during that transition from the ureter to the bladder. So I see a lot of questions. Literally all of these questions will be covered in the next few slides. So I'm not going to answer them right now. But based on everything we've learned and hopefully some basic anatomy that you guys know, thinking about our patient and thinking about what we've just read already, which of the following is the most likely site of obstruction in this patient? Please answer on menti.com and let's see what you guys think. Okay. Yeah, so just looking at the chat, yeah, the location of the stone, size of stone, these all can affect your management, particularly. So we're going to have a chat about that very shortly. Okay, let's have a look. Nice. So I'm glad because we kind of discovered this. It makes very logical sense. But I will also touch on why the other options are incorrect as well. But yes, PUJ, pelvi-ureteric junction, is the most likely site of obstruction. So the reasons why the others are incorrect are all described here. I'm not going to dwell on every single one of these answers. All the slides are available at bitemedicine.com/watch. But the key point here is that for your exams, you really need to know the next slide because this comes up in exams all the time. Urology consultants love to grill people on this. My dad is a urology consultant, and for some reason he loves this question, and he asks all his juniors this question as well, which is, what are the three most common sites of obstruction in a patient with renal colic?
The explanation of all the answers on the previous slide we'll re-upload that with all the explanations on them. Essentially, you just need to learn these slides. So urinary stones classically cause obstruction at these 3 major sites. So starting at the top, like we mentioned, the PUJ, pelvic ureteric junction of the renal pelvis and the ureter, that's number 1. Follow the ureter down at the pelvic brim. So as the ureter enters the pelvis, crosses over your iliac vessels, particularly, you know, if you look closely here, you can see that this common iliac artery is actually branching off into your internal and external iliacs. This is classically another point where it's compressed where obstruction occurs, sorry, at the pelvic brim. And then finally at the VUJ as the ureter enters the bladder, as we touched on previously. So in terms of a little bit of pathophysiology based on this slide, so imagine there's an obstruction at any of these points. The obstruction occurs, prostaglandin is released. So there's a couple of things going on. So prostaglandin is released, and this actually causes vasodilation of your renal vessels. When this occurs, this causes a natural diuresis, which then actually puts further pressure on your kidneys. So that can cause pain in one respect, but also obviously that natural peristaltic action of the ureter against the obstruction is also causing pain as well. So remember, your ureters have smooth muscle, so those are two kind of different ways that this pain is even arising in these patients. So that natural diuresis and the peristaltic action against the obstruction as well. Nice. Now this is something which comes up very commonly in exams. It can be a little bit of a drag to learn about, so I'm going to try and make this as interesting as possible. But essentially, we want to know about these main 5 types of renal stone. Here's our pufferfish as well. This is a calcium oxalate stone. So let's have a chat about calcium oxalate stone. So overall, calcium stones are the most common type of stone. Overall, calcium oxalate stones are the most common, accounting for around 75% of stones overall. Essentially, there's the precipitation of calcium crystals in the interstitium, and this then acts as a focus for stones to form. Now, the question is, what is going to be causing this calcium precipitation to occur? Well, if you have high levels of calcium in your blood, so hypercalcemia, this can then cause high levels of calcium in your urine, so hypercalciuria. The conditions like hyperparathyroidism, where you have hypercalcemia, this can then cause your calcium oxalate stones, which makes total sense. Similarly, if we look at the second part of the word oxalate, high concentrations of oxalate, which then pass into the urine, can also cause calcium oxalate stones. And we're going to touch on oxalate in a little bit, in a few slides. And then finally, just another concept to be aware of is that in our bodies, we have natural stone inhibitors. So 2 things like, for example, citrate and magnesium naturally prevent stone formation. So if we have a loss of those stone inhibitors, then that can also promote the production of stone. So that's just a couple of things to be aware of as well. Now, envelope shaped, what that's referring to is actually what it looks like on microscopy. You don't need to know this for really any clinical reasons, to be honest, but it often comes up in exam. So remember, calcium oxalate stones are envelope shaped. Now, the next point is really, really important because a lot of people get confused. What does radio-opaque mean? What does radiolucent mean? Well, in the context of renal stones, radiopaque essentially means that the stone is visible on a plain radiograph. So as you can see in this image, I'm not sure how large it is on your screen, but you can see the stone up here, for example. It's radiopaque, so you can see it on a radiograph. That's because of the calcium. So on the whole, most stones are radiopaque because they contain calcium. If you do a plain X-ray, you will see the majority of stones. So calcium oxalate being one of those examples. So hopefully that all is pretty straightforward.
So now we have another type of stone. We have this one on the right. This is a struvite stone. These are tapioca pancakes from the Festival de Tapioca in Portugal. But we'll move away from tapioca pancakes and think about stones. So this is a struvite stone. These account for around 15% of stones overall, and they're composed of magnesium, ammonium, phosphate. Magnesium, ammonium, phosphate. That's what struvite essentially is made of. They're also described as triple phosphate and infection stones, and I'll explain why now. So the reason why they're described as infection stones is because they're associated with urease producing organisms. The two main ones that you guys need to know about are Proteus and Klebsiella. Remember those two. Those ones are urease producing organisms. Now, essentially what happens is that they convert urea to ammonia, which then reacts with water and then increases your pH. So you get alkalytic urine, and that increases your risk of struvite stones. Now, these stones can become very big, these struvite stones. They can form what's known as staghorn calculi, as you can see here. Really large branched pelvic calculi, so within the renal pelvis, which then branch into several or all of the calyces. So that's really, really important. Good, and these are mildly radio-opaque and under microscopy look like coffin lid-shaped crystals. Moving on to calcium phosphate stones, less common than calcium oxalate, but have similar etiology, so hypercalcemia, so conditions of raised calcium. Another key one is renal tubular acidosis. So this is when the kidneys can't properly acidify urine. And yeah, particularly type 1s and type 3. So that's just something to remember. And these are very radio-opaque. So if you do a plain radiograph, these will essentially look like bone. That's how they're described. The calcium phosphate crystals are very radio-opaque and look like bone on radiograph. Nice and easy. Second to last stone, uric acid stones. So these are associated with low urinary pH, so acidic urine. That's point number one. Remember that. These are associated with acidic urine and also high levels of uric acid, as you would expect. So we have to think about anything that's going to cause acidic urine. So where, for example, when you're dehydrated in hot climates, you generally produce acidic, low volume urine. So that in and of itself is a risk factor for uric acid stones. Then we need to think, what's going to increase our uric acid level? Well, as I'm sure we know, when purines break down, you get uric acid being produced. So if we think about gout, gout is associated with hyperuricemia, so high levels of uric acid in the blood. This causes high levels of uric acid in your urine, and that can cause uric acid stones. So just remember gout, some forms of malignancy, particularly the treatment of malignancy as well. When you get rapid turnover of cells, this can also cause the production of uric acid stones. They look like they're rhomboid shaped on microscopy, and these are radiolucent. So this is essentially a normal X-ray. So you can't see anything here. So they're radiolucent. And then finally, cysteine. These are semi-opaque, so sometimes you can see them a little bit, but very rare, 1% or less overall. They're associated with cystinuria, so this is an autosomal recessive disorder. It's a key relationship to remember as well. So essentially cysteine then precipitates in your renal tubules and you get cysteine stones. And understandably, because cystinuria is an hereditary condition, a lot of these stones normally present in patients that are younger than you would expect. So I had a look at the literature. The literature says different things, but as a general consensus of a lot of these stones occur in patients in their 20s, often their early 20s as well. So yeah, cystinuria, hexagonal shaped, semi-opaque, and may cause multiple stones as well. That's super high yield stuff, but yeah, remember those key points and you'll probably be okay with stones, stone types. But have a look at our textbook. We do a full textbook chapter on this, which goes into a little bit more detail as well.
Now, before we move on to the next question, some other risk factors just to be aware of. So I touched on oxalate before. So like we said, things that can cause calcium oxalate stones are things that are going to increase your calcium, but also things that are going to increase your oxalate. So if we think about Crohn's disease, I'm sure we all know, Crohn's is a form of inflammatory bowel disease. Where does Crohn's most commonly affect? Which part of the bowel? Terminal ileum, exactly. So patients with Crohn's disease, particularly terminal ileal disease, or if they've had a resection of the terminal ileum for whatever reason, for example, Crohn's, then we need to think about how that's going to affect you physiologically. So if we think about a normal patient, this is actually, I generally find these quite interesting. If we think about a normal patient, in most of us, what's going to happen is that physiologically, once calcium is formed, it usually combines with oxalate and is then excreted in the stool. That's what usually happens. So we need to think what happens in Crohn's. Well, in Crohn's, you have malabsorption. So you have fat malabsorption. So there's loads of fat hanging around in your gut. All this fat in the gut then actually binds with calcium, which leads to free oxalate roaming around your gut. This oxalate is then reabsorbed and goes into your bloodstream, goes into your urinary tract, and you can get calcium oxalate stones. That is why Crohn's is associated with calcium oxalate stones, because of that oxalate absorption, primarily due to the fat malabsorption. So I think that's really important to know, because if you can't really visualize that, and obviously most of this is occurring within the ileum, that's why it's relevant here. So now that you know that physiology, hopefully that will make sense and you won't forget that. I'm not going to go into the pathophysiology of all of these because it could get a little bit complicated, but be aware of foods that contain oxalate. So we've got chocolate, rhubarb, spinach, nuts, tea. All of these can increase your oxalate levels and can cause calcium oxalate stones, which is super important if you've got a patient who's presenting with recurrent calcium oxalate stones. You need to give them advice about how to reduce that oxalate intake. And then finally, a couple of drugs here, which are associated with calcium stones. I'm not going to go into the exact pathophysiology, because if we do that for everything, we'll be here all day, as much as I love talking about pathophysiology. But yeah, have a memory of that slide. If you can't recall everything I said about Crohn's, this will be uploaded and have a listen. Okay, now back to you guys. So having a think about our initial patient, the 35-year-old chap, who's come in with what we think is a right-sided stone, which of the following would be a red flag feature? Okay, bring this up. So which of the following would be a red flag feature? So something that you would be worried about. In this case, we're looking back at this question. I mean, hematuria, whether it's macro or microscopic hematuria, either of those, it shouldn't really affect the answer. Let's have a look at what you guys are thinking. Interesting. Wow, I didn't know these would be so controversial. Okay. Fever, boom. So let's have a think. So first of all, why is fever correct? Well, fever in the context of a suspected stone is essentially almost a urological emergency. As soon as they develop a fever, above 38, you're very, very concerned because you have a stone which is obstructing the renal tract, the urinary tract, which has then caused an infection which can spread up to the kidneys, and it will be an absolute nightmare. So that is a red flag. These patients will need urgent urological input, particularly if the fever gets worse, they get septic, they will need a procedure, which we will talk about in a little while. Hematuria, which was the other big option, which there was a split between. Hematuria can occur in a renal stone, macroscopically or microscopically. It's more commonly microscopic, but the presence of macroscopic hematuria alone is not a red flag, I'd say. And vomiting, as we mentioned, is common, and tachycardia secondary to pain. So yeah, fever is very worrying because it suggests an infection associated with that stone. And I'll touch on renal angle tenderness and what that is on the next slide. Here we go. So I think we've actually mentioned most of these bits and pieces. So the acute, severe loin to groin pain, classically described as colicky, so intervals of no pain or dull pain. But in reality, often that pain can also be continuous. Nausea, vomiting, some lower urinary tract symptoms such as urgency or frequency as well. Hematuria, which is usually microscopic, and then fever, like we said, a red flag feature, which suggests a superimposed infection. Now, there are a few questions about what renal angle tenderness is. Well, it's pretty straightforward. Essentially, we know that the kidneys are a retroperitoneal structure. You can percuss on the patient's flank, essentially near their back, where the kidneys are. If you remember your surface anatomy, know where your kidneys are, you can percuss there. And if there is pain, that could suggest pyelonephritis, it could suggest a renal stone, it could suggest a perinephric abscess, so an abscess in the kidney. So yeah, that alone is not a red flag, but it's important to pick up on that. And I mean, if I suspect renal pathology in any patient, I assess for renal angle tenderness. And then hypertension and tachycardia for sure, very concerning. But tachycardia alone, if a patient is in severe pain, is not really a red flag because the tachycardia is likely secondary to the pain. If you treat the pain, they are still tachycardic, then you're thinking, is there something else? Was the patient really dehydrated? If there are clinical signs of dehydration and you've treated that and they're still tachycardic, well, then we definitely have a problem. But the combination of hypotension and tachycardia, suggests shock with sepsis. Good, and then here's this chap here presenting with his loin to groin pain. I guess the point here to remember is that wherever the stone is, the pain, you can't determine the location of the stone based on the pain. That's point number one. Some stones can be asymptomatic, really small stones, for example, and can be picked up incidentally. And a lot of these stones can pass themselves depending on their size. So 3 other points from this slide as well. Okay, now, before I look at that, actually, you might have those on your slides already, but I wanted to tell you a quick story. So as I said, my dad's a urologist and he likes to tell lots of stories. He told a story to me probably a year ago of a patient that presented to A&E, 60-year-old male, presented to A&E with kind of some abdominal back flankish type pain, had a renal stone before, and had been assessed in A&E, hadn't had any imaging, and was sent up to the urology ward. That really should never happen. You should always have at least your basic imaging and have a diagnosis before you send the patient up to a ward. Obviously, in this case, they are suspecting a renal stone. They send him up to the urology ward thinking, oh, this is a renal stone, give him some pain relief, blah, blah, blah. But it ended up being a ruptured AAA, and the patient unfortunately ended up dying. So the point here is that particularly in older patients, male patients, even if they have a history of stones, you really need to think of a AAA, so abdominal aortic aneurysm, which is what this slide is saying. So always suspect AAA in older males. Don't always assume it's colic because they've had a previous stone. Don't assume it's colic because it sounds like colic. Really, these patients, even if you have a slight suspicion of AAA, should have an ultrasound in A&E, ideally. So yeah, remember that. A few other differentials here, which I'm not going to go into too much depth about, but there are some key differentiating factors here, and you can discriminate between these two based on these key points. So yeah, AAA is the one I really wanted to focus on. So don't assume it's a AAA simply because of their pain. You have to take into account their age, their gender, their cardiovascular presence or absence of cardiovascular comorbidities. And if you have any suspicion of AAA, scan their abdominal aorta in A&E with an ultrasound. Not you, but someone with expertise in that. So AAA is just abdominal aortic aneurysm. Good, okay, so moving on. You can see this journey has moved on a little bit. So his pain has settled with some diclofenac. His urine dip shows microscopic hematuria, and his observations are now normal. What is your imaging of choice in this patient? Bring this up. Okay, a few moments. So what is the difference between microscopic and macroscopic hematuria? Microscopic is picked up on a urine dip. Macroscopic is you can see it with the naked eye. I.e., the patient will say, I've got blood in my urine, for example. Sarah, yes. So if you have a ruptured AAA, for sure they'll be hemodynamically unstable. But if you have a leaking AAA, remember, if you have a look back at our shock lecture, profound hemodynamic instability doesn't occur until stage 4 shock. So if it's leaking, for example, he could have been sent to the ward and then he totally ruptured on the ward, for example. That would be one explanation of it. Okay, let's see what you guys think. Fantastic. Okay, so the majority of you are absolutely correct. Non-contrast CTKB, gold standard as per BAUS guidelines for renal stone. We'll pick up the vast majority of stones. Essentially, if you're suspecting a stone and you do a non-contrast CTKB and that imaging is negative, the patient can be said not to have a renal stone. You need to think of a different diagnosis, essentially. A very high sensitivity and specificity. There are a few reasons why you might do a renal tract ultrasound. So if radiation must be avoided, so for example, in children, pregnant women, renal tract ultrasound may be considered. MRI abdomen pelvis not performed. You don't need contrast for this procedure. Particularly, I mean, it's actually very useful because a lot of these patients may have underlying renal impairment. The fact that you don't need contrast is brilliant. So non-contrast CT is all that's required. And this will kind of demonstrate the size of the stone, the site of the stone. And as we said, if it's negative, you can essentially rule out a stone as well. Nice. Okay, some investigations. We've touched on a few of these already. So we like to split these up either into primary investigations and investigations to consider, or bedside and blood. The bedside investigation, so urine dip, of course. And if you're a female, along with that urine dip, what else are we going to be looking for? Female, 30 years old. What else are we doing? Exactly, pregnancy test, always. Bloods, key bloods here. These are directly from the BAUS guidelines. They all make total sense. Remember, if you have an obstructing stone, you can get pressure back up towards the kidney, also known as hydronephrosis, build up of that back pressure, and you can get deranged renal function. So make sure you assess the patient's renal function. Bone profiles, blood cultures, and coagulation. I think that all makes sense. As we said, gold standard imaging is a non-contrast CT kidney, ureter, bladder. So that's what KUB stands for. Guidelines say within 14 hours of admission. I mean, in reality, should happen a lot quicker than that. Obviously, if the patient's septic, you're suspecting a septic stone, that needs to happen essentially immediately. And then some imaging to consider, like we mentioned, renal tract ultrasound, X-ray, essentially abdominal X-ray or X-ray kidney, ureter, bladder. Not commonly performed for stones. It's not, if you have a suspected stone, normally you would go straight to a CT KUB. But as BAUS guidelines say, if you're a known stone former, they've had a recent CT KUB, they're presented with their usual symptoms of stones, then you may be able to avoid some of that unnecessary radiation with a CT and do an ultrasound or an X-ray. Okay, so moving on, the patient's had a CT KUB. This is how we like to learn medicine, is this journey of the patient. So I mean, we've treated him, we've done some investigations. What do we do next? So CT KUB shows a 15mm right-sided mid-ureteric stone. So remember that. The bit in bold is the thing you need to remember. What is your first line definitive management options? 15mm mid-ureteric stone. Difficult question, but 100% could come up in your exams. Let's have a look at the questions. Yeah, and that's a good point as well. In terms of contrast and non-contrast, you're absolutely right. If you, as well as the fact you don't need contrast, if you have contrast, then you can actually miss stones because you've got a lot of white everywhere. So yeah, that's a very good point as well. Okay, let's have a look. Interesting. Interesting. Nope. 18%. Okay. Let's learn about the management of stones. So I guess the key point here right now is that, to be honest, there isn't 100% consensus in the management of stones. There are BAUS guidelines, there are European Association of Urology guidelines, there are NICE guidelines. Thankfully, they do agree with each other in a lot of respects. So that's what the guidelines we have created are based on, all of those combined, which we think is the best way to do it. So generally, first line surgical management for a 10 to 20mm ureteric stone is ureteroscopy, and we'll talk about what that is. So this was a 15mm mid-ureteric stone, so you want to do ureteroscopy. 15 is big, you know, it's unlikely that's going to pass itself. You know, you could do watchful waiting. You could tell the patient, you know, if the stone was 2mm, for example, you'd say, oh, the stone is probably going to pass itself, stay hydrated. If the pain gets worse, come back, blah, blah. But, you know, the key point here is that this stone is way over 5mm, so you can't just watch and wait. And then we're going to talk about the other options and why they aren't appropriate in the moment. Now, I popped this slide in. It's a little bit different to what we normally do. But I think it's really important when inevitably you'll probably need to have a job in the emergency department. And, you know, I've seen many, many stones during my time working in A&E. And this is really the main information that the urologist will ask at the other end of the phone when you're referring a patient to them. Obviously, the basic details, a brief background, you know, I'm sure you guys know about the SBAR approach, situation, background, assessment, recommendations. But in addition to that, these are some key points to focus on. Have they had a stone before? Are they a known stone former is essentially what that is. The severity of their pain and vomiting, and their response to medication. The reason this is important is that, yes, patients can come in with a lot of pain, but if you've given them diclofenac, you've given them ibuprofen, you've given them, you know, you might have even leaned towards opiates and paracetamol, etc. as well. If they're not responding to that, they're vomiting, you know, and still in severe pain, this really suggests that they're not going to be able to work with a watch and wait approach. These patients will need to come under urology because they'll still be in significant distress. Presence of fever, features of sepsis, red flags, needs immediate urological input process. So make sure you have the renal function before you make any phone calls. And then CT-KUB, this is really the information that they want. Good. So have all that before you make any phone calls to urology, basically. This is the general guide. Okay, now management. First line, I think we've touched on this already. Fluid, antiemetics as required if they're nauseous or vomiting. Analgesia, we talked about the importance of NSAIDs. Conservative or medical management. So, as I said right at the beginning, the vast majority of stones are going to pass spontaneously. So small stones, less than 5mm, most of those will pass by themselves. You will give the patient advice. You can send them home with analgesia. You can send them home with antiemetics. You will say, if the pain gets significantly worse, you can't start vomiting a lot more. If you develop a fever, you must come back.
this is important advice that you would give these patients, and you would say, we will expect this stone to pass out in your urine, so keep an eye out in your urine to see if there are fragments of that stone that are being passed. That's the basic advice you'll give to these to these patients with small stones. Another kind of medical option would be medical expulsive therapy. As I mentioned, some of these guidelines are a little bit controversial, so that is particularly in the case of medical expulsive therapy. So this essentially means you give a medication such as tamsulosin, which is an alpha blocker, and that can help the stone to pass down the ureter. So normally for 5 to 10 millimeter stones, and particularly beneficial if they are distal ureteric stones. BAUS, they don't routinely give medical expulsive therapy, which I think makes sense, but they do also agree that there is some evidence of benefit with drugs such as tamsulosin. Nice. So that's the nice straightforward parts of management. And the 90% of patients I've seen in A&E with stones have actually been managed like this. But we need to think about other management options. So let's touch on what the funky terms I'm about to use are before we talk about the actual flowchart. So extracorporeal shockwave lithotripsy, also just known as lithotripsy. Got a stone, you're trying to fragment those stones. Boom. So you basically use, it's non-invasive, it utilizes high energy sound waves to try and break down that stone into fragments. It's externally applied high energy sound waves. Boom. Uncomfortable, it requires analgesia, and there is a risk of actually damaging internal organs. Those are just a few things to remember, and it's contraindicated in pregnancy. Those are a few bullet points. So in pregnancy, you shouldn't do lithotripsy, but it's appropriate for some stones. So remember that. Ureteroscopy, also known as URS, which we're going to touch on in the next few slides. Essentially, you pass this device here, which is known as a ureteroscope, into the urethra, into the bladder, and into the ureter to either retrieve the stone, as you can see here, or kind of break it up with actual lithotripsy, which is attached to the ureteroscope. So a couple of options there. So that's what, when I'm talking about ureteroscopy, that's what I mean. And that's done under general anesthetic. PCNL, the percutaneous nephrolithotomy. This is my very crude drawing of it, but essentially it's a minimally invasive procedure for renal stones. So remember, only renal stones, not ureteric stones. Small incision in the back and you remove the stones. So normally for really large renal stones. And that's generally done under general anesthetic as well. But now you know those three procedures. Hopefully this won't all be alien to you. I'm not going to go through absolutely every one of these boxes. I recommend learning these in your own time. As I said, these are based on the European Urological Association and NICE guidelines. We've combined them to come up with this general consensus. So as we said, the management is going to be based on where the stone is and the size of the stone. And yeah, I think I've explained all of these procedures. And then that's the ureteric stone pathway. And kidney stones, slightly different. And as I said, there isn't 100% consensus on this. But yeah, I'd recommend learning the key points, which are small stones less than 5 millimeters, regardless of where they are, can generally do watchful waiting and discharge, telling the patient about those red flags. You only give medical expulsive therapy generally for smallish ureteric stones, particularly if distal. And then you can consider some of those procedures that we touched on the previous slides as well for slightly larger stones. So yeah, essentially memorize that table in your own time. We've really simplified that for you guys as well. Now, a couple more procedures that you guys need to know about for the upcoming slide as well is a percutaneous nephrostomy. So essentially what a nephrostomy is that it's the placement of this bag. So you place a small flexible rubber tube through the skin into the kidney and you're draining urine. Now, having worked in urology, you see a lot of these procedures being done, usually under local anesthetic and often as an emergency. So if the patient has urosepsis and has a known stone, the key is to really decompress the urinary system. So you're trying to decompress that and remove that back pressure on the kidneys to prevent renal failure, essentially. And that's why you might do a nephrostomy. Yeah, so that's really important to remember, and that's exactly what it looks like. And the other one is ureteric stenting. So you can see this on the left. This is known as a pigtail or JJ stent. Essentially, it's an endoscopic insertion of a stent under general anesthetic, often done, well, can be done as an emergency procedure for a stone with associated urosepsis as well as a nephrostomy, or as an alternative to a nephrostomy, I should say. It's a temporary procedure. You can see on the imaging here, you can see the stent. It's, as I said, it's temporary. These are normally in place for 4 weeks. Shouldn't really be in place for significantly longer than that, because these stents can kind of become encrusted, they can migrate, and they become a little bit of a nightmare. So the red arrows here show the kidney stone. The yellow arrow here shows the obstructing ureteric stone. And that's why we've passed up this JJ stent. And this is really important. I think I started my urology job and I didn't really know much about these stents, but I'd really recommend that you have some understanding of it, because when you see patients either in A&E or you're doing urology, you see these, then now you know what they are. Remember, they're temporary and it's a stent, so you're trying to relieve that obstruction. So hopefully that makes sense. And yeah, the reason we had to know those two procedures is because we need to know how to manage patients with sepsis and an obstructed kidney, or patients essentially with anuria, so their kidneys are no longer producing urine because of the extent of this obstruction. These are urological emergencies. So any patient with sepsis specifically, in the context of a renal stone or ureteric stone, you need to discuss with urology urgently. I feel like I've said that so many times, but it's really just hammering that point home. The guidelines state quite explicitly is that there is no evidence to support the superiority of a nephrostomy, which we showed you on the previous slides, or a ureteric stent. The decision is going to be based on kind of logistical factors, surgeon preference, etc. But the key is, you're septic, you have an obstructing stone, we need to relieve that back pressure, we need to give antibiotics, but you need to treat the infection and remove the back pressure on the kidneys. Otherwise, you can develop renal failure, essentially. Does that make sense to everyone? This is, a really, really important slide to be aware of. Yeah? Okay. I'll assume it makes sense. Cool, so we're coming near the end now, up to our top decile question, which I think is the most popular part of the webinar. I mean, we've touched on most of these. If you don't treat, the stone can become infected, you can develop urosepsis, hydronephrosis, because that back pressure on the kidney is developing into renal failure. And then you obviously have, like with any procedure-related complications, ureteric injury, bleeding, sepsis, and then here's one specific one, so a lithotripsy-related hematoma as well. Now, in terms of prognosis, I mean, I knew that stones often recurred in patients. I wasn't aware of how significant the recurrence rates actually were. So looking at the evidence, it shows that 50% of first-time stone formers experience recurrence at 5 years. So half of patients who present with one stone will present with another stone within 5 years. And at 10 years, that number is 80%. So almost everyone who has one stone is probably going to have another one within 10 years, which I still think is crazy. So always give discharge advice, regardless of whether you've treated the patient or you've done the watchful waiting approach. Make sure they comply with lifestyle modifications, so remaining well hydrated,
reducing your protein and salt intake if appropriate. You know, these basic things as well are really important. But also remember, most stones will pass spontaneously, particularly if they're less than 5 millimeters. But these patients should also have follow-up. Normally in a stone clinic is where we would follow up patients. Okay, top decile question, here we go. Now, this is a tricky one, I must say. It's a competition. It is a competition. So let's get as many of you here as we can. The quicker you respond, the higher number of points you get. We don't have any prizes, but we will say well done and give you all of our love. Okay, let's get a few more. So answer as fast as you can. There'll be a leaderboard at the end, and we'll see who's won. Okay, ready? Let's go. Okay. Which of the following would not be visible on a non-contrast CT-KUB? Read the question carefully. Read the question carefully. Yeah, just looking at the chat. Shuaib, right? I do have a table on the management of renal and ureteric stones, but it differs slightly between British and European guidelines. Oh, wow. Okay, that kind of was a top decile question, then. That's good. Yeah, that was filthy, I must say. Good, well done. 31 of you is brilliant. Okay. Let's see the explanations, and then we'll have a look at the leaderboard. Okay, that is essentially the answer. So this actually can come up in your exams. It's mainly just one of those pattern word recognition type questions. So indinavir is a protease inhibitor, i.e. it's a form of antiretroviral therapy for HIV, and it's characteristically linked with radiolucent stones. So remember we talked about radiopaque versus radiolucent. Remember, when we're talking about this, we normally are talking about how this looks on a plain film. If we say radiolucent on a plain film, we normally mean on an X-ray, you're not going to be able to see it. But in the case of indinavir, it actually means that when you do a CT-KUB, so non-contrast CT-KUB, you actually still can't see it. So the majority of stones, vast majority, 95% above of stones, are generally going to be visible on CT-KUB. But there are a tiny minority, such as indinavir stones, which are not. The other ones, as explained here, are not the correct answer. So hopefully that makes sense. Let's see which superstar got the right answer. Oh, that was a tight. Smexy. Nasli, congratulations. Take a bow. Fantastic work. You deserve a prize of some kind, but you have all of our love and congrats. Okay, how do we move on? Let's try and move on. It's not letting me. Ah, there we go. Recap, just in time, I think. All the main summary is basically here. We know the difference anatomically between renal and ureteric stones, but both different types of stones with different risk factors, has that characteristic presentation that we described, but always exclude your important differentials, rupture AAA, ectopic pregnancy, appendicitis, etc. All patients need a urine dip, basic bloods, non-contrast CT-KUB, and a pregnancy test in women of childbearing age. The majority of patients can manage conservatively, stone will pass by itself. There are multiple surgical options though. Make sure sepsis in the context of a renal or ureteric stone is referred immediately and managed immediately as well. And then the lifetime recurrence is actually very, very high. So if you enjoyed that, before we hand out the feedback form for your certificates, if you liked this style of questioning, we think it's the best way to learn. We looked at the evidence and that seems to suggest it as well. Our question banks are exactly the same style as this, so working through the entire patient journey. So we would definitely recommend it. So please check it out at biomedicine.com. Now, I'm not sure how many you get for free, but you get a large number for free as well. Our online textbook as well, based on the most up-to-date current guidelines, are up on our website as well, with around 300 topics now. Oh, lots of references. And there we go, there's the feedback form. QR code, hopefully Schwabe or Zach will be popping that in the chat as well. Please join us at Biomedicine for Students. Thank you so much for joining us today. I know that plenty of other better things you could potentially be doing right now than watching a webinar on renal stones, but hopefully that came in handy. If you have any questions for me, I'll try and stick around and answer some as we go along. Well, right now even. Okay. Why do we use ureteric stenting instead of removing the stone straight away? Well, I guess what we need to think about is what's the priority here? The priority in a patient with, I'm assuming you're talking about, are you talking about in the context of sepsis? Then often we will do a stent, because a stent or a nephrostomy, because the priority is not to remove the stone, the priority is to treat the back pressure on the kidneys to prevent renal failure. Giving IV antibiotics, preventing that back pressure, the hydronephrosis, are the priorities in sepsis in the context of a renal stone. So that's when stenting is performed. Stenting is not usually performed just for a standard stone. It's normally performed in the context of sepsis or anuria. Is a link to the feedback form. Hopefully Schwabe is posting that now. Is percutaneous nephrostomy temporary or permanent procedure? Nephrostomies are temporary on the whole. Do we need to check for calcium levels in patients with renal stones? If you're working in neurology, particularly if you have recurrent stones, you should do that. These stones are often then also examined under microscopy as well to see what the stone's made of as well. But like in A&E, it's not 100%. It's not really your responsibility to diagnose the exact cause of the stone. But obviously, if you add on a bone profile and it shows that you're thinking outside the box and thinking of the causes, it's totally reasonable to do as well. Oh, lots of questions. Did you mention that you contrast for Indinavir stone? Yeah, sorry if I didn't make that very explicit. For an Indinavir stone, you would need to do a CT urogram essentially. So you need to use contrast. So that requires contrast to find an Indinavir stone. How does hydronephrosis occur in renal stones? I mean, it's relatively straightforward conceptually if you think about it. You've got kidney, you've got ureter, you've got smooth muscle around the ureter, and you've got an obstruction within the ureter. You've got that obstruction, you've got the peristaltic action of the ureter against that obstruction. That will cause the proximal part of the ureter to dilate. The pressure within the ureter will increase, the pressure on the kidney will increase, and that can cause acute kidney injury and renal failure. How do you visualize radiolucent stones? Non-contrast CT-KUB. Remember, the lucency is only related to radiographs, plain radiograph in general. CT-KUB will pick up the majority of stones, regardless of if they are radio opaque or lucent on plain radiograph. Did you say loin-groin pain experience? Yeah, so often the pain, you essentially can't diagnose or specify the location of the stone simply based on the pain. Pain will be often similar dependent on, regardless of where the stone is. Let me keep scrolling down. What investigation do you rule out to rule out AAA? First thing you're going to do is an ultrasound, abdominal ultrasound, look at the abdominal aorta.
Who makes the diagrams for your slides? We make that ourselves. Schwabe, Zach, and I, and Rich have all learnt to make diagrams, but so a lot of them are taken from non-copyrighted sources as well. That's a long question. Keep scrolling, keep scrolling. A lot of these I've answered already. How does urosepsis cause hydronephrosis? So you don't need urosepsis to cause hydronephrosis. A large obstructing stone by itself, in the absence of sepsis, can cause hydronephrosis because of that back pressure we described. The point is, if you get sepsis in the context of a stone, then that infection is probably going to be tracking up to the kidneys, and you can get acute renal failure, and patients die because of that. So that's why you need to relieve that pressure on the kidney. Why can't you fly with a renal stone? Great question. So I actually got taught this by urology, like ST7, so it's quite a senior registrar. He said, always tell patients not to fly if they've got a known stone until it's passed. My A&E consultant didn't agree with that, but I've spoken to a few people, and generally urology consultants say you shouldn't, mainly because if you start spiking a fever on a long-haul flight and you become acutely unwell and get urosepsis because of your stone, no, I mean, what's really going to happen? You're going to be in a lot of bother stuck at 35,000 feet with urosepsis secondary to a stone. That's the big reason. But also, you know, stones can recur. I mean, not recur, but, you know, that stone can migrate and get lodged at a different point, and you can get that pain back again. So yeah, but the main thing is going to be you don't want to develop urosepsis whilst on a flight. Okay, I'll take a couple more. How would you treat hydronephrosis? In the context of an obstructing stone, a couple of those options we touched on. So nephrostomy, stenting can both relieve that obstruction, but also all the other procedures we discussed as well. So PCNL, all of those will essentially relieve the obstruction and relieve hydronephrosis. You haven't messaged. I'll message you. Okay, I'll take one more. I'm going to be getting a bit peckish. What would be, okay, where's, oh, my chat keeps moving around. If the stone is less than 5 millimeters but causing constant pain, discomfort, then for how long can the patient take analgesia and analgesia for that side effects too? Yeah, that's a very good question. So I would, this is the reason I mentioned about when talking to urology and the patient with the stone. Even if you have a stone of 4 millimeters, which is kind of teetering on that 5 millimeter cutoff, but they are in severe pain, not responsive to NSAIDs, not really responsive to anything. They're vomiting, and that's not responsive to antiemetics. It's totally possible. Then these patients should really be admitted. You should try and optimize that, and these patients may still receive surgical management, regardless of the size, because as you mentioned, you know, giving whacking pain relief for days on end with absolutely no effect is it's not really going to be beneficial. So yeah, that's just something to bear in mind as well. Cool. I think I'll call it a day there. Hopefully that was useful. Thank you so much for joining us today. Thank you for filling out the feedback form, and yeah, check out our website and see you on our Facebook group.